So I'm Amy Cohn. I'm a faculty member in the Department of Industrial Operations Engineering, which for those of you not in the department is right over there. It's the building that it's the offices you can't get into because of the construction. However, there are, I believe now, at least available restrooms like as you head up towards the door. So I'm faculty in Industrial Operations Engineering, which is home to the Center for Healthcare Engineering and Patient Safety. So if you're affiliated with CHEPS, if you could raise a hand. So we've got a number of students who are working at CHEPS on projects. We've got some students who are both working on projects and enrolled. If you are an industrial engineering student, an IOE student, raise your hands. If you're public health, if you're nursing, oh, be proudly. Like a lot of the work we're going to be talking about at some point this semester in the emergency department, Lainey was like one of the key players in. So who did we not get? Do we have data informatics or health informatics? Excellent. Computer science. Formerly IOE PhD, now temporarily employed before joining the VA health. Anyone else? Anyone else?
Manufacturing engineering.
Manufacturing engineering.
Steve Cronak, emergency medicine.
Perfect. Okay, so this class is a combination of operations. We're going to be talking predominantly about operations within a complex health setting. We are merging this with work that we're doing through the Center for Healthcare Engineering and Patient Safety, or CHEPS. And we are also linked in with the Michigan Medicine Health System through a role that I spend half of my time on the health side. So this course started off as, if you're going to have a center, you have to have a seminar series. And we thought we would bring in engineers who had worked on problems in healthcare to talk about the work that they had done. That was a lot of fun. We had some great talks, but one of the things that we realized was when we teach, largely teach you about how to solve problems. We give you a problem and we teach you how to solve it. And one of the most challenging things I would argue in complex systems, and in particular in healthcare, which largely stems not from people with engineering backgrounds, but people from healthcare backgrounds, yes, is the idea that, welcome, make yourselves comfortable. The idea that we don't actually know what problem we need to solve. Right? Frequently understanding the problem that we need to solve is very hard. And in addition, when you have that problem and you think you've solved it, is your solution going to actually work in practice? And is it going to mess somebody else up? So what we decided to do was to shift a little bit. And now what we're doing is instead just brainstorming about what is the right problem, how do we tackle it? So the goal is number one, from an educational experience, for those of you enrolled in IOE 813, to get used to this idea of, I don't know the right answer. And you're not expected to get the right answer. And frankly, I tend to keep note, and I actually end up with awards or little gifts or something for the person who comes up with the most ridiculous, preposterous flying monkey. Right? That some of the craziest ideas are going to be the ones that trigger something else, or at least trigger someone like Steve to say, no, that's impossible because that's not how it works. I didn't know that, so now I've learned something. So from an educational standpoint, learning how to scope problems, learning to be comfortable being uncomfortable, learning to get used to the idea that this might be a disastrous class. I might start talking and we might just not go anywhere. I don't think that's going to happen because we got a whole lot of ED docs who, if nothing else, have a lot of ideas about the problems that they're trying to solve. From the perspective of our clinical partners, what we're really trying to do is just bring a new set of eyes and a new set of disciplines to this work. So there are going to be things that you're going to ask that Steve is immediately going to go, no way. And then I'm going to give him a hard time because why not, Steve? We can change EMTALA. I mean, it's not a law of physics, right? We could, in theory, change EMTALA if that was the right thing to do. And Steve's going to go, no. And then Steve and I'll go back and forth for a while about EMTALA. And then finally, you're going to raise your hand and say, what's EMTALA? And then I'm going to turn to Steve because I don't remember what it stands for. But in the meantime, we're gonna see how this goes. So today's class will be a little different because I'm not a clinician. But I've been doing a lot of work in the emergency department. And so that seemed like a good way to get you started. So we've done our pre-read quiz. If you're either on Zoom or here, but not taking the course, we really would appreciate you're either scanning the QR code or just emailing one of us your email, your unique names, so that we can, again, get the college to continue supporting time for us to do this. I've already done my introduction. The way most of these sessions will go is we're going to start with some background information to just kind of level set. So those of you enrolled have already done some reading, you've gotten some terminology, you've gotten some jargon, but for the rest of you who hopefully have not spent much time in emergency departments unless you're in ER doc, give you a little bit more context. And then we're going to introduce a challenge. And I want to kind of push back on the term problem. To me, emergency department crowding is not a problem, because a problem to me implies that there's a solution. It is this much broader challenge that we're going to have to tackle in many different ways concurrently. So we'll talk about what is the challenge that we're concerned with. Today's challenge is emergency department delays and crowding. In case you're interested, for anyone on Zoom, can someone check the chat for me, by the way? The topic next week will still be staying in the emergency department. Dr. Andy Fine, who's a pediatric ER doc at Boston Children's Hospital, is going to change the focus a little bit, and we're going to be talking about the issue of pediatric patients, so children, teens in severe psychiatric crisis, and the issues of their time in the emergency department as we try to find bed placement for them in an inpatient setting. And then once we understand why we have a problem and why this problem is important, we're just going to start brainstorming. And we're going to talk a little bit about the types of questions we want you to be thinking about, the lenses we want you to bring. The bad news is I'm going to be calling on all of you. The good news is there's no wrong answer. And it is always acceptable to say, actually, could I ask you a question first? And then just say anything, right? So I call on you, what's your name?
Patrick.
Patrick, I say, Patrick, what do you think we should do in this situation? And Patrick says, actually, before we do that, you never did tell us what EMTALA stands for. And then he's off the hook and it's fine, right? If you're really stretched, if you're really feeling like the tie from career day or the pointy shoes that you're not used to wearing is constricting blood flow, you've been thinking about what you're going to have for dinner, you can just kind of nod and say, yep, yep. And it'll be good, okay? This is not about embarrassing you, but if you're not comfortable asking questions and saying stupid stuff, we don't get anywhere. So like, set your goal to say the stupidest thing or the most outlandish thing or the most preposterous thing of the class, okay? That is your goal. You're competitive, you're gonna say something just completely outlandish. All right, we're ready. So we've done the quiz. If you haven't scanned this, there are pieces of paper floating around. We've already talked about me. Okay. Why do people go to the emergency department? Actually, I've got a question first. Nikki, what ER shows have you watched? Give me one.
Grey's Anatomy.
Grey's Anatomy. How many of you understand what an emergency department looks like from Grey's Anatomy? Okay, so what have you watched?
I don't know if I've watched any healthcare shows.
This will be an interesting.
I have watched House actually.
Okay. Okay, so you've watched House. I am binging The Good Doctor. That's what I put on when I'm on my treadmill, and I'm like one episode away, and I'm already anticipating withdrawals. So we have a couple of people maybe who remember George Clooney when he was a young doctor. ER, Grey's Anatomy. Not really what your average day looks like, is it?
No.
Why do people go to the emergency department? We're going to start with just something, anything. Why would you go to an emergency department?
Broke a bone.
A broken bone. Good. George, why might you go to an emergency department?
If you get in a car accident.
Car accident. Irving.
stroke symptoms.
Good, good. Patrick?
A lot of people just need urgent care. You know, they don't know where to triage, they just show up.
I don't know where to go. I can go there. Shasha? Allergic reaction, Daria?
You have OCD and you've convinced yourself that the bacteria is eating your brain.
Have you ever had that?
Sure.
Yeah, all right.
Not me personally, but
What's your name?
Tasman,
Tasman.
your water broke, you're giving birth.
Yes, yes. We have one of my former students having a baby today, so I'm very excited. I think giving birth is like the joyful reason people go to hospitals, right? So that's a good one. What have you got?
Getting a ride so that I can get downtown. People abusing the ambulance system.
Yep, yep. Okay,
it's an expensive ride. Yeah.
but if you're uninsured, does it go somewhere else? Speaking of uninsured, Marina. Not that Marina's. I started with that and I switched subjects.
No, it's Saturday night and you're a college student and you're
And it's.
a little inebriated
Give me some credit.
or a lot inebriated.
So random fact, it turns out for those of you who are undergrads that our pediatric ED serves you until until you turn 21 or until you turn 21. I'm not gonna go there. I have a good friend who's a peds ER doc and his son just started at Michigan. Good conversations. Anyone on Zoom? Tell me why you might go to the emergency department that we haven't talked about. Someone, please. What have we got going in the chat?
No questions. Oh, lack of primary care.
Lack of primary care. Yes, Nick.
You might have to go to the bathroom at Michigan Stadium and foolishly run up the stairs and split your knee open and need 17 stitches.
Hypothetically speaking, that was strangely precise. We missing anything?
Chest pain.
Julie?
Everything else is closed and your child has a fever and there's nowhere else to take them because the urgent cares are closed. Physician is closed.
Nothing's up and what's your name?
Chris,
Chris.
I'd say mental health or like suicide.
Mental health.
You spontaneously passed out.
Who's passed up? Yep.
Maybe you have an issue with breathing or something gets lodged in your throat. You just can't breathe.
George?
From the chat, there is chest pain, unable to get an outpatient appointment, stitches, mental health crisis, no housing. My doctor sent me in and suicidal attempt.
I guess just any kind of pain where you're like, I don't know what to do, and you start freaking out. I guess then you would just go. It could be anywhere.
Yeah, and I want you to lock that thought in for like 10 minutes. And when I go, by the way, Matt, just have that thought top of mind, okay? All right, let's see if we missed anything sort of odd. So I always thought, because I watched ER, that it was car crashes, gunshot wounds, got struck by lightning while I was doing construction on a roof, got run over by a car while I was doing construction on a roof, right? That like that trauma kind of stuff. And then there's also heart attacks, strokes, respiratory kinds of things. Lack of access to primary care. Someone elaborate on what you think that means and what others in the room might not. Go ahead.
So with primary care, you may have been able to prevent something that now that you talk about primary care, this chronic condition's built up to where you have an acute symptom where you have to.
Go ahead.
During the Delta wave of COVID, I worked in a morgue in pathology. There was a lot of amputated diabetic limbs because of exactly this, where people were not going in because they were immunocompromised or whatever. They didn't want to go in and get the help that they needed, and then things spiral. So.
Yeah, Lena.
Could it also be something that like you shouldn't go to the ED for, but you couldn't get an appointment with your primary care doctor, so you walk into the ED to get whatever care that you needed?
Yeah, so I think it's helpful to split into kind of two categories. There's the, I'm coming to the ED to get primary care because I don't have primary care. And yeah, I'd go see my doctor about what is probably strep throat, except there's no doctor to see. And Steve, I want to preface this by saying, don't assume I know what I'm talking about. And I'm gonna pretend that when I'm actually not at all right, I'm doing it on purpose, because one of the things that we want you to get used to is in trying to solve problems in these domains, you need to get lots of information from lots of people. And no one's lying to you that I know of. No one's intentionally trying to mislead you, but my information may be very limited to, this is actually only true at Michigan Medicine, but I assume it's true at every health system, and I make that statement. Or this was true 5 years ago and we've changed things, but I don't know it anymore. So Steve and Ben, if you're on, and the folks from the Carolinas, you're gonna jump in, and in a gracious way, to not embarrass me in front of my students on the first day of class, say, exactly, Amy. And now I'm gonna say the exact opposite of what you've said. Right. Feel free to jump in when you disagree. You should always question and verify, use data, ask 5 different people the same question. And if 5 answers don't match up, then you want to keep digging deeper. So some of the work that we've been doing with Lainey and Jade and else so far, who else is on Red Sea for this semester? She's not here, okay. We heard a lot of people say, this happens because of that. And then we pulled data and that isn't actually true anymore. So I'm gonna continue to act as though I know what I'm talking about, and I'm gonna continue to count on Steve to tell me when I'm wrong, but I can go because I don't have primary care. Or I can go because I didn't have primary care and things got worse and worse and worse, and now I actually need the emergency department. Why might I not have primary care? Yeah.
You know, insurance.
I don't have insurance, right? And why might I not have insurance?
Too expensive.
Maybe it's
job.
largely tied to employment, maybe too expensive. Go ahead.
This was like an actual situation that happened to me, but I had a PCP for my entire life. And then I moved away for college, didn't see him for a couple of years. And it was like after COVID, so they weren't seeing any new patients. So then I was a new patient because I haven't seen him for a few years. And so I couldn't get back in there. So I had to get a new PCP.
Yeah. And do you have any idea, Steve, what the wait time is to get a new PCP in the Michigan Medicine Health System?
I'm not sure we're taking new patients right now, to be perfectly honest. I think we've fixed that for a while. We had no primary.
Yep. So we tend to think of disparities, we tend to think of income inequality. All of those things are very important and I want to keep them front of mind. But you can be very affluent and have healthcare be a catastrophic event. Largest cost of bankruptcy, personal not business. Illness, largest cause of mortgage default, healthcare expenses. So I might not have a PCP because I don't have insurance. I might not have insurance because my company offers something very bare bones that's expensive and has, you know, a $10,000 deductible and sort of catastrophic care. And you're young and you're healthy. And why would you need a primary care doc and why do you need insurance? Or there just isn't one. Right? Just I'm waiting for months to find one. Uncertain symptoms. So Mick, I was kind of thinking about this, like, wouldn't it be nice if there was a magic way, giving hint for people who in a few minutes are going to be asked questions and are feeling a little anxious about this? Wouldn't it be wonderful? Here's my first flying monkey. I go, I have this pain here. It could be a heart attack. Or it could be the 3 chili dogs I ate while watching the game. If I think it's the chili dogs and I'm wrong, something really bad could happen. So what is the default? The default, if I don't know whether something's really wrong or not, is Right? What if we had some mechanism to help understand what was a chili dog before you actually arrive at triage, right? Anybody here ever heard of machine learning? Right? I don't trust machine learning right now to tell me whether or not I'm having a heart attack. Do you trust it yet to tell you if you're having a heart attack? But 10 years from now, what do you think of the odds that we're gonna be doing some triaging with machine learning and some sort of you can already buy the credit card, right? The thing you put your thumbs on. Patrick,
I mean, already, I don't know if this is like widely known or not, but like 90% of pap smears are machine learning processed, so. All women do that, so it's already happening.
there's reading of radiology images and right, and to some extent, I also want to think about machine learning's a buzzword, NLPs, artificial intelligence, predictive, and at some point, the range of what counts is pretty big. There's some predictive modeling or some machine learning or something going on with triage, right? You come in and someone says, without full knowledge, I'm making my best guess about how sick you are.
You know, but I was just said that, you know, people are using it now. I mean, so we see people every single day who put their symptoms into ChatGPT or just Google, and they come up with, I'm having this.
Yeah.
You walk in the door, you're convinced that they have that thing.
How, do you have a sense, and I'm gonna ask the folks on Zoom as well, our clinicians, how can you do the spread between the number of patients who've come in because they've seen something online and it's ridiculous, and the number of people, I shouldn't say ridiculous, when it's the middle of the night and your baby's turning a different color or crying or your foot's doing something weird, the internet has resources, right? So to what extent do you see people coming in where they've gotten really bad information and shouldn't have come in versus people who, oh, they were able to make a wise decision, or their spouse was able to say, no, honey, seriously, look at this, you need to go in.
Well, the spouse is by far the best. Just at all. People would be dead all over the place if they didn't have spouse. It's like, you know, would never be here except, you know, it's usually the wife, you know, told me to come in. But it's a combination of both. I mean, so what I don't know is how often it had an impact on whether or not they would have come or not. Yeah, that's the thing that's hard it's hard to know that they would have made a different decision without that information.
Yeah, yeah.
I mean, there's no double blind study we're going to do to say, you know, you get to use the internet, none of you people don't get to use the internet when you have something.
That's what I was gonna say, is I'd be interested to know what percentage of people are finding bad information and not coming in as a result. Because, yeah, this happened to me, but like my dad was having a heart attack, but he was like 45 at the time, so he was like, there's no way. And so for like 12 hours, he was just like, it's probably just like, I'll just take Pepto or whatever else. And after a certain point, we were like, guy, let's call an ambulance. So like,
Yeah, there's actually some interesting research going on in obstetrics and gynecology. So going back to our baby topic, there's a faculty member in OB-GYN and a faculty member in computer science. And what they're looking at is using, fill in your favorite computer science term of choice, to scrape the web, looking for places where there is bad information that is likely to be found, and in particular likely to be found by women who either don't have a good social support network in terms of lots of, you know, sisters, moms, aunts, friends who've had babies, good resources in terms of getting information, and possibly not having a lot of good health information available to them, but trying to be able to say, gee, there's all this stuff running around on the internet right now. So when you type in like, I'm pregnant and I threw up, that some nonsense is going to come up. And if they can anticipate what people are hearing that's wrong, then that can actually influence their practice in terms of, we need to proactively make sure our patients know that that thing, no, like that's not what you should actually be doing. So, again, this issue of, I don't know if I need to come in or not, and in general, the default, so like, if you don't know if you need to come in or not, then you don't know that you don't need to come in, and there's an asymmetry here, right? Because the cost of going to the emergency department when you don't need to, asterisk, is much lower than the cost of not going to the emergency department when you do need to. Except for the folks for whom going to the emergency department is actually financially catastrophic. Okay? Or I suppose for the cases where you go to the emergency department and you catch COVID in the waiting room because you didn't need to be in the emergency department and therefore you're potentially waiting for a fairly long stretch. Minor injuries that need urgent attention. Another question for our ED docs. When is the right time to use urgent care? So for example, I'm bleeding and I think I need stitches. Is urgent care a pretty good bet that you're gonna get stitches, you'll get out of there a lot faster?
Probably. I mean, it's hard to tell. I mean, I think they do a pretty good job of screening people that need additional care and then they have to go to an emergency department.
That's before 6 p.m. If you need stitches after 6 p.m., urgent care is closed for the most part.
Do we have 24-hour urgent cares in Ann Arbor at all?
So I needed stitches at 6:05 a few years ago. And I actually called U of M emergency department and they told me, no, like some of them might still be open, but they're not gonna see you before they close, so you just come here.
We have something, there we go. George.
Dr. William Jackson previously said Dr. Google is one of the referral sources. And he just said, it depends on the experience and training of the personnel at the urgent care.
Sure.
Public service announcement for our students. University Health Services, for many things, can get you through faster than the ED. We've had a lot of conversations about students who, especially if you're new to Ann Arbor, new to the university, new to grown-upping and something goes wrong, it's not an uncommon response for mom and dad to be like, go to the emergency department, unless you're capable of doing so. It's worth calling UHS's 24-hour number because there are certain things that, again, they can get you through much more quickly. And they're also very connected with Michigan Medicine in terms of being able to say, no, you need to go to the emergency department. Mental health, we're going to talk about this a lot next week, so I'm going to suggest we not spend too much time. But this is a major challenge that we're going to talk about next week. So someone mentioned social environmental factors, so homelessness, domestic violence, the ED is being seen as a safe place. It's the middle of the night and I'm out of my medication and I need my medication. There's nowhere else to go. Okay. Steve, did we miss anything?
No, I mean, all these things are right. So I mean, it's basically, you have some level of discomfort. And that can be, physical, it can be mental. And the other thing is that the, sort of the acuity of it also, and that varies by person. I can't wait. It's something I must take care of now. And that, that's a hard thing to, I don't know, legislate's not the right word, but to say that, it's appropriate to or not to come, because that's all individual. Either I can't tolerate this any longer. Whether it's, again, I might not be able to, and somebody else might say, I can wait, 3 days to take care of that.
We forgot one, actually. We forgot kind of an interesting one. So you see your doctor and they say, I really think, you see your cardiologist, your primary care doctor, whatever, and they say, I really think you need an MRI. And they try to schedule the MRI. And the MRI is solid. Paula, if you show up at the emergency department, Paula says we can't. What does EMTALA stand for?
So EMTALA is the Emergency Medicine Treatment and Labor Act. And and it's very more involved in this, but the idea is that if you show up at an emergency department, they have to see you and they don't have to do everything. They have to do at least something called a medical screening exam, which means that they have to check you out, make sure you don't have a medical emergency. And they can't send you someplace else before stabilizing to the best of your ability. So part of the idea is that in labor too, you can't just kind of say, put you in an ambulance or get in your car and go someplace else because we don't want to take care. You have to take care of people. And so most places do that by not just saying, checking to see if you don't have a medical emergency or not. They, we take care of you.
So there are times that people will choose themselves or their physician will say, I can't get you in for X amount of time, but if you show up at the emergency department, you'll get this test. Now,
Well, but you don't necessarily. I think what happens in a lot of EDs is that, the providers there recognize that that's the problem, and that they won't get it for, so it's the right thing, but it's gonna be weeks, a person can wait days, but they can't wait weeks, and so they'll just say. But not every place does, and a lot of places say this, it's not something that's gonna happen here.
George.
In the chat, it said, no one wakes up in the morning and says, I wish to spend it in the ED.
Yep, I think that's a pretty safe bet. Not that ours isn't quite, yeah. This is not what we set out to do, right? We're not going there because we have other options. Okay, so what happens when you go to the ED?
Intake.
Everyone that's there is kind of like prioritized based on the severity of your symptoms or like illness.
How do you get to the ER? Yeah,
Uber.
Yeah, you might show up by Uber. You decide that I need to be seen and get an Uber. Why would I bother doing Uber instead of just calling an ambulance?
The pricing of an ambulance, so.
Right? If you're having chest pain, is the first thing that you do to check your insurance policy to see how much the ambulance ride is gonna cost you? A lot of people do, right? A lot of people make that decision. Shashank, you were gonna say something, I think.
Yeah, isn't there like, if you're in a big city, you can also just walk in, depending on.
So there are people who walk in. There are people who come in by Uber or whose family members drive them or drive themselves. There are people who come by ambulance.
I think going back to the ambulance thing, I think it's so interesting because in my home country, like my aunt, I'd be like sniffling or something and she'd be like, are you sick? Do you want me to call you an ambulance? I'm like, an ambulance? Like, what do you mean? I gotta be dying for you to get an ambulance. She's like, no, the nurse will come check on you.
That's a country where pediatricians make home calls if your child has a cold.
So we could spend a whole, maybe we will at the end of the semester, a whole lecture or more on different national healthcare systems and how it intersects with their culture, financial models and so on. So I can show up, I can present, I can come by ambulance, I can come by life flight, I can get transferred from another hospital. I show up and some point, what is the average time to get through triage?
So we've done time studies on this. So the actual triage process takes about 8 minutes. So besides the acuity bit, which is a huge part of it, is that everybody gets screened when they first come in. There's all a lot of regulatory screening. There's a lot of safety screening. Do you have something that's infectious that they want to have you around other people, they want you to be masked, you should be in respiratory isolation. Have you been exposed to something that, would require you? So there's a lot of screening that goes on. There's a lot of regulatory, you at risk to yourself or others, or you feel safe. All these things that we're required to have. So all that stuff goes on too. So it's a number of steps, because we have large volumes and we'll do sort of a upfront screen of those things. Are you safe to be where you are? Do you need to go right back? And then if not, we get vital signs, which is another sort of time where we might say you need to go right back. And then you go to a second stage where you would get, more of an in-depth screening. What's going on? What kind of conditions do you have? Which is again, another layer of where you might say, oh, because of that, now you know, even though everything else looks fine, you need to go right back.
So we come in, there's some waiting, there's some assessment, there's some more waiting. That more waiting might be a little bit, might be a lot more than a little bit. Now I'm actually being seen. There may be testing done. We may be waiting to get the test. We may be waiting to get the results of the test. There's a process of diagnosis, figuring out what's wrong, what we need to do, treatment planning, and then eventually, where do you go? What happens when Dr. Steve says, I've done my job here? Where do you go? Nick,
Sometimes you just go back home.
you go home. The stitches are in, the bone is set, the prescription's given to you, and off you go. Yep. Where else? Laney.
Patient unit,
Mhm. And what does that process look like?
they have to figure out a place to put you in the hospital, and then you end up boarding for like days.
Sometimes, so the term boarding. Boarding is, I'm in the emergency department, but I am under the care of a hospitalist, an inpatient doctor. So they're making follow-up decisions and managing my care, but I'm physically taking a bed in the ED. The ED nurses are still, it's ED nurses, not inpatient nurses if I'm boarding, correct?
Yes, for us, yeah.
Because they're the ones physically there. And until there's a bed open in the hospital itself, I can't send you home. You need to be hospitalized. I can't put you in the hospital. There's no place to put you. We stay in the ED. So that's when people talk about boarding. Go ahead, Julie.
There's observation too. So like if you're not sure if I want to keep you overnight, I can put you in an observation. So you're like in a room, but you're still not officially admitted. That can be multiple days.
Yeah.
In-home hospitalization.
So you need to be hospitalized, meaning you require. So much of this is driven by insurance definitions and decisions, right? So what does it mean to be, there's observation units, there's observation status, there's observation protocol. I can be observation status, but in an inpatient unit. I can be inpatient status, but in an observation unit. I can be under an observation protocol. And why does it really matter? Payment stuff largely, right? So as we think about turning off our phone, as we think about, Daria.
Yeah, the at-home patient, like at-home care made me think about, I work as a caregiver as well, and we had to set up an at-home like hospital, and so much of the time, and I worked for the caregiving company that was kind of helping streamline all of this, but it was, instead of focusing on like the care that they needed, we were focusing on, wait, how do we format this in a way that will insurance will cover it, and then the company, because like the caregiving is a third party company, and then the hospital has its own requirements that they're saying, and it's so much like paperwork instead of just like, here, let's focus on the care right now, like we need to get this pneumonia under control or something like that.
So an enormous amount of decision making in the US health system is driven by the underlying financial models of the US health system. What I want to do time-wise, let's see. Okay, so are you starting to feel like you have a more comprehensive view of what this process looks like? I show up in many different ways for many different reasons. I probably wait a bunch. Nobody woke up this morning and said, I want to spend the majority of my day, right? Or more than a day. I go through some process. We ultimately make some decision about what we think the diagnosis is, what the treatment plan is, what the disposition is. So do I send you home? Do I send you into an inpatient bed? Do I send you to a skilled nursing facility? Can you think of any other challenges or issues with the where do I send you? So Ben or Steve or Dr. William, I've lost track of who's on Zoom, have said, okay, we've done our job. Everything should be done, right? What's our last set of barriers possibly? So who haven't we heard? Go ahead.
Patient non-compliance.
So we can have,
Patients who refuse to do whatever it is you're asking them to do is the next step, whether that's going home or
yeah, and the reason I'm hesitating is
picking up and leaving the ER without having permission or whatever.
so I'm gonna think about synonyms for non-compliance. But I wanna, George, go ahead.
So getting prescriptions or follow-up care.
Yep, so it may be an issue from the perspective of the patient not being in alignment. And the reason I'm fussing over compliance is in many cases, what is perceived as non-compliant and therefore is assigned blame and therefore biases the treatment of a patient may not be, I'm not willing to do what you say, but there's something beyond that. But so we have this issue of I'm not ready to leave in the sense of I spent several hours in an emergency department arguing with an ED doc who was saying that my dad was just fine and it was time to go home and I was not leaving. That there are those circumstances where there's some dispute. There's the issue of but I can't leave until you give me the prescription, so I'm waiting for the prescription. Go ahead, George.
Lack of timely follow-up care.
As reason for not leaving?
Check.
Okay, well, I think that's probably the sort of circle back of ending up bouncing back.
This patient not having the social resources at home to be able to take care of themselves.
So I'm 83, I've just broken my leg. You've put me in a cast, you've given me a pair of crutches, you've said, we're good. Except Steve says, vaya con Dios, you're all set. Here's a bottle of some pain pills, here are your crutches. And I live on a 3rd floor walk up and it's snowing out and my son lives in the UP. And it's gonna be 14 hours before anybody can get here. Do we just say, what do we do? Right? That's not an easy question. I've come in and the reason I'm here appears, or maybe I've acknowledged, is domestic abuse. Do you say, okay, I've done the stitches or the wound healing or whatever, and like, now we're, all right? So what are the things that we need to do that aren't necessarily the jobs of the physicians, but that still are necessary when we think about our goal is not to treat a disease, right? It's for a person to be healthy and well. So what's not working? We wait a lot. This statistic is, I think, really misleading. So on average, patients wait 30+ minutes to see a provider in the emergency department. 1 in 4 wait over an hour. Steve, Ben, what's the average wait to get out of the waiting room? I mean, you can mention right now, ballpark.
So, I mean, it's misleading because it varies, right? I mean, 'cause we talked about acuity and all these other things. And so that I think we do a really good job for people who are acute and need the care quickly, you know, get it quickly. But, you know, patients that can wait or have problems that through all that triage and that we think they can wait longer, will wait longer.
Yeah. Patrick.
I just want to second that. Like when I broke my clavicle, I sat there for 3 hours because they were like, there's nothing we can do. We can give you, you know, pain meds, but so I was low priority. And that's kind of the ball game.
Julie?
I think that it's not average, but the variability. So, I mean, I've been in the ED for like 6 hours easily. And it's unclear whether it's just because of.
So we've got long wait times. We've got overcrowding. We've got this notion of ambulance diversions, so the idea of an ambulance diversion is when an emergency department says, we are so busy, don't have ambulances come here. And what's any idea why we don't really do a lot of ambulance diversions? Because the other places are frequently just as bad. How often would you say we divert to, say, St.
So
Joe's?
we have I don't know if it's really, it's an actual agreement or a gentleman's agreement, because the only really big hospital in town is Trinity Health, in Ann Arbor, and so, they're very similar to us, and so if we're full, they're typically full. I mean, our volumes really kind of are massive. It's really rare that we are crazy busy and they're just wide open, or vice versa. So we've just said, we're just never gonna go on diversion, because then in a minute, you're gonna be on diversion, and so it doesn't make any sense. We have both gone on very brief diversions for really like disaster thing. And when I say disaster is the place is literally on fire. There was a fire in the cafeteria and all the smoke was pouring into the ED. So we said, we'll divert. Or the ORs go down, there's some sort of power problem, or the cath lab goes down. We both had that where we call each other and just say, for the next, 2 hours, or whatever it is. And we do have the policies in place so that we can divert for specific things. So, because to be wrong, I mean, to bring somebody with a heart attack to a place that doesn't have a place to treat it.
So, yes.
Who makes that call, like under a diversion? Who makes that call and what's that chain of command like?
So it's the attending in the emergency department with the charge nurse, and you call, medical control, and there's a whole policy around, you have to update them every 4 hours, and you have to, do a bunch of stuff to make sure that you're doing it all kind of by the book.
So I don't want to spend too much time, but it's not working in a lot of places, right? We have a lot of waits. I think, Julie, to your point, it's not only the variability, but it's also like the sort of cyclical time of day of week, seasonality kind of trends, that there are times that it's not so bad, and then there are times that it's really bad. Issues of resources, patient dissatisfaction, impact on healthcare costs, lots of delays getting into inpatient beds. Let's see what they put on the next one. Okay, so why do we care? Well, first of all, because you could get worse, right? If I'm sick and I come to the emergency department, I'm waiting, I can get worse. If it's crowded, people overlook things sometimes. This is, in general, as engineers, we don't like chaos, right? When you think about controlled systems, we don't like chaos. The burnout factor for our providers. When it is always, there are certain dashboards in our healthcare system that, they're color coded by red, green, yellow. And there are certain dashboards that I get on a daily basis. And you got to ask yourself how many days, weeks, months in a row something can be read before you sort of question that, like, what does that actually mean? To say, you can't say, well, it's just normal, so we shouldn't call it red anymore because it's unacceptable. But at the same time, what's the point of flagging something as red if it's always red? So we've got, these burnout issues. We're not diseases or injuries, we're people. I can come into an emergency department with a sprained ankle, but also have a respiratory illness that makes me highly susceptible to the person sitting all around me. We have concerns about how expensive the care is. Are we providing the right care? And a lot of this stuff is in the readings that you've been given and the references at the end, so I don't want to take too much time. But it's not just that people wait for a long time, right? It's also, I'm in the emergency department waiting to be seen, and I'm looking at my watch because in 2 hours my kid gets out of school, and my 7-year-old's gonna show up at the bus stop. I need to not be here when I need to be there. Okay, so what I'd like to do now is to talk a little bit about strategies. And so as you're glancing at this, should I do that? Okay, so we've been sort of working with a construct that I find very helpful that we've been calling the DAISY process. So diagnostic analysis of integrated systems through industrial engineering. Now, unfortunately, there's not a good way in this classroom, like the screens block the board, but it's not a great picture anyway. But I want you to think about how do we go about figuring out what to do about this, right? So Michigan Medicine has an emergency department that is not operating the way we would all ideally like it to operate, right? How do we fix it? So I'm gonna kind of put at my core, this is, well, it's not even fixing the ED. There are lots of things that could be defined as fixing the ED. So we're gonna focus on this idea of crowding and delay. If you were to go home and tell your roommate, the history major, like you spent all day talking about emergency department crowding and everything else, and you said, so they've got, tons of people in the waiting room, they've got tons of people. And let me be clear, no one is doing their job wrong, right? This is not about blaming individuals. It's about understanding underlying root causes of a system. And that's important because at the end of the day, it still is people doing those jobs and doing those frequently under pressure. So we want to keep coming back to the notion of the system, the operations, the processes. So you go home and you tell your roommate, the history major. So, emergency departments all over the country have like tons of people in the waiting room. They're waiting a really long time. How do you think they should fix this? What do you think the kind of gut reaction of people might be? To me, it seems like there's a sort of simple, obvious solution, right? What's the simple, obvious solution?
Expand it.
Make it bigger, right? So we could increase capacity. If you have more doctors and more space and everything else. Can somebody give me a reason why that would be a good idea? Yep.
Serve more people, need more beds.
I have more doctors and I have more space, it becomes, at some point, it becomes concierge service, right? I'm like, hey, Steve, hurt my ankle running. What you got for me, right? Okay. Can somebody give me a reason why it's not a good idea? Daria.
I feel like it's all about proportions. If you increase the capacity, you're gonna be accepting more people because you're like, oh, we have more bed space. We can now you can't turn away people, but I don't know. It doesn't necessarily work. If you look at big highways, they're still gonna have, if it's like a 6-lane highway, you still have traffic jams.
The demand is non-stationary. And so you could say the demand is not, and what that means is if you told, I'm on the fence, feeling kind of, and you say, maybe I should go to the emergency department. But I'm gonna sit there for 14 hours. I'm gonna feel really awful in the waiting room. There's a range of how awful I feel where it's not worth it. If you told me I could get seen immediately, I'll come in. So and it's interesting when we think about access, which we'll be talking about later in the semester for just general care. So I'm trying to get into see an orthopedist because I want to get my hip fixed, or I'm having a problem with my knee playing tennis or whatever. The shorter the wait, the more people who come, which then pushes the wait. So Daria's highway example is when you increase the capacity of your highway system, more people say, oh, it's not that bad of a delay, more people start driving again, okay? So if you increase the capacity, if you build it, they will come, right? And I would suspect that in many cases, you'd start seeing people of lower and lower acuity, because if I can go to the emergency department right now and get checked for a strep throat, why am I calling my primary care doc and making an appointment tomorrow? I'll just show up because there's capacity. Yeah.
I'm sorry, can we go back? What does DAISY stand for again?
Diagnostic analysis of integrated, I made this up yesterday, of integrated systems through industrial engineering. You're gonna see in a minute. Okay, so Steve, if we were to just give you 5 more doctors, how much would that help ED crowding?
Zero.
Why?
Because it's not, we have plenty of doctors. It's the space to see the patients that we're suffering from right
If
now.
there's no place to put the patient, I can't treat them, right? Well, you do in the hallway, don't you?
Well, we do. So we have been very adaptive by creating using non-traditional space to provide care. So, I mean, something like 28% of our patients, I looked at this a few months ago, of our discharge patients were seen in a hallway or a chair.
So capacity, I want to be clear as we're drawing these examples, there's not one solution. And I, as an industrial engineer, and you as a public health, you as a data scientist, and you as a manufacturing engineer, we all have a different skill set and different lens. We're going to come at these problems in different ways. So here's one option. But I don't want to really dig into that option because I don't think I have much to add to that option. Frankly, the increased capacity thing starts getting into finance, but it also starts getting into like the purpose of our ED and what is the volume that we want to be supporting and all sorts of stuff that I don't think I'm going to be able to do much with.
Well, exactly. Traffic, I mean, nobody ever solved the traffic problem by building a bigger parking lot.
That's a really good point. Okay, so if increasing capacity is not going to solve the problem, or maybe it is, but I don't know how to do it. George, what have you got?
Someone said increasing capacity is expensive and leads to increased demand, and there's a question of why is this an issue in all parts of the country, in every ED? Are all hospital system decision makers making the same decisions, same choices?
So, well, I'm not gonna answer it a little bit. So it varies a little bit. So I mean, you think of our situation where a lot of places will try to kind of shuffle off the lower acuity stuff, the urgent care stuff, because it's rapid throughput and if you come up with streams for the various types, then you might be more efficient. We have a very small percentage of low acuity stuff just because we're a university place and people come to us with, they're sick. I mean, they have a lot of medical problems and that's why they come to us. So that'd be one thing that would be different for us. So there is some differences between places. And so there are different problems and different ways of approaching them.
There's also just general crisis in healthcare. It's not just part of the reason EDs are a mess everywhere is because primary care is largely a mess, which feeds into it, which brings me back to my question. Yes.
Say faster diagnostic testing.
Okay, so one way that I could improve the ED is if I can get patients through more quickly, right? So if instead of me getting into an exam room or a treatment room or whatever you call them and staying in that room for 18 hours, if I could stay in that room for 3 hours, you could now get 5 more patients through, if I do my math right. So we can, I'm just for simplicity's sake, I'm going to call this improved throughput, because we're industrial engineers, so we have to occasionally use this language. Okay. So I could get the patients that I have through faster.
Decrease demand.
How might it decrease demand?
You can have the patients like self-classify themselves as whether it's necessary to go to the UD or not.
So this is Mick, what I was talking about is we could build some really good AI models, maybe, that allow us to, I mean, remember, it's flying monkeys, it's like magic wands. If I could build a magic wand that said, no, you're not having a heart attack, you pulled a muscle, you're fine till tomorrow, take some ibuprofen, that would reduce demand on the emergency department. You were gonna say something other than that, and then Marina.
Yeah, I was just gonna say patient education. If the patients kind of know what they're kind of dealing with, maybe they've experienced in the past, they can learn from what was going on before and possibly not want to come into the ED from there. So
Marina, are you still in this bucket?
Kind of.
Okay, go for it.
So, I mentioned I did have to go to the ED with a genuine emergency, and I called before I showed up to ask for their advice. The reason I called them is because I owned a dog for many years, and their animal emergency room, and they are very strict about, unless your dog has literally been hit by a car, call us before bringing them in. We'll advise you over the phone. We'll try to not have you come in. We want to triage over the phone as much as we can. And obviously that doesn't apply to all the cases we discussed, but for some situations, you know, having this information more prominently available and really encouraging this, I think can be helpful.
Nurse triage lines, yeah.
Someone said smarter triage systems with disposition decisions not tied to diagnostics.
Good, Lena.
Kind of in the like throughput bucket, I worked on a project in the ED where a lot of their crowding was because inpatient rooms weren't being cleaned fast enough for them to be available for patients that needed beds. So like this idea of not just looking at the ED, but looking at other parts of the hospital that impact like the ED.
Absolutely. Irvi, and then I want to continue.
I was gonna actually talk about the nurse triage, because I know like U of M has a system where you can call, and get like advice from a nurse, and like I did that last week. And that could potentially also falls into like the education bucket of making that easily accessible.
So when we think about decreasing demand, one way we can decrease demand is to better inform people, to improve the decision-making of do I need to go or not? How about people not being as sick? I'm pretty sure that at some point, some component of ED went down when we launched collapsible steering wheels and seatbelts, right? If we in public health, and part of what I want to do is, again, this emphasis on there's a computer science kind of AI aspect to, oh, could we build these models that better predict whether or not you really need to go? We could do this more industrial engineering of the ED is slammed right now, but if you wait 4 hours, you can wait 4 hours in the emergency room, waiting room, or you can wait 4 hours at home and then come in at a time where the cycle sort of ebbs and flows. Public health possibly is the place that says, you know, if more kids got flu shots or more senior citizens got flu shots, we might see fewer respiratory or more COVID uptake, or more kids getting their asthma inhalers. And, you know, maybe it's an environmental component of, in certain communities, little kids are coming in with asthma attacks because of the air that they're breathing. Or the health economists looking at what can we be doing to make it actually most effective? How do we align the incentives to say it's actually better for whom I don't know? Is it better for the hospital, the health system? Is it better for the insurance companies? But is it somehow an alignment that, boy, if we start having a lot more primary care, if we really beefed up primary care, we would potentially see a decrease in demand for emergency departments. Okay, so we can decrease the demand, we can improve the throughput. Julie.
Doesn't that suggest that, like, when we say increase capacity, it's a matter of where that capacity might be, that it's not just in the ED, but maybe it's urgent care, maybe it's like virtual visits, maybe it's like other places where the capacity is insufficient, and that's why load comes to the ED.
I like that a lot. If we think about, I want to come up with one more pedal before we keep going, actually. Too much time left. So I can make the ED bigger. And the reason I like having this here is I think it's the default for a lot of people. You walk in, you look around and you go, why don't they make it bigger? This to me is kind of the ideal, frankly. Like, if people don't need to come to the emergency department, that would be a good thing. But some of those are really hard. If I can get them through faster, then that is effectively increasing capacity. There's one more piece. So fewer people coming in, people spending less time when they're coming through.
Balance the load, but there's not as much variability in it. Try to flatten it out.
Yes, I like that, and I would probably keep it in here, but I think it's a good point, is it's not, improving throughput is not necessarily saying this patient takes less time, it's by smoothing things out. What's my last pedal? Any ideas?
trying to get them out as soon as possible.
Expediting discharge. So we talked about, I'm in the ED. Steve says, you're ready to go. Here are your crutches. Go for it, 82-year-old lady. And I don't leave, right? Or Steve calls upstairs, Ben calls upstairs and says, hey, I've got a patient with a cardiac condition who needs to be admitted. And they say, great, we'll call you when we've got a room, right? So if we can get people out faster, right? And so I want to kind of make this case for saying, all right, any one of these may have potential benefits. What is the space that is going to be most beneficial to work in as a combination of the opportunity, the effort, and your skill set? I'm an industrial engineer. I look at this because I say, you know what, this is both really hard and it's a skill set I don't have, right? The notion, and it's also, in general, I would argue non-immediate, right? To improve the air quality in an inner city and improve the access to healthy foods so that I have fewer kids coming in with asthma or that there's less diabetes is something that's should not be taken off the table, but maybe that's not the right project for me to work on, right? So let's come over here and let's try another flower. So I want to improve throughput. How can I improve throughput? Go ahead.
Just streamline the process. Right. To get out the ED.
Okay, let's think about the process. What are the chunks of the process? Go ahead.
Maybe like improve the rate of like admission into the ED, so people like entering it.
I'm gonna think about that still as being part of our reducing demand. Yeah.
Improving communication between departments.
Why?
So if someone's like at a bottleneck and they're waiting on their papers to go through, or they're waiting on their doctor to talk to their nurse, that'll go faster.
Good. So let's break down communication a little bit more. And I want to think of communication to some extent as, I need the word. I don't know the word I want, but communication may be the tactic to solve a more refined problem. Go ahead and then we'll come back to this.
So on the front end, it could be triage.
Okay, so let's triage you faster, more effectively.
On the back end, it could also be transition teams. So transitioning outside of the ED and putting you in the proper, whether or not you're placed in ICU or to discharge, yeah.
Good. I think it's helpful to think temporally. Give me 1 second, Jade, and then George. For me, in this kind of thing, I start with, well, if we're trying to reduce the length of time to go from here to here, what's the first thing we do? We triage. Steve, if I can make triage faster, would that make everything better?
No.
Okay, so, you know, at some point I might want to think about it, but that's probably not the best strategy for my problem. Jade, sorry, I almost forgot you.
Bed availability, bed, and more beds.
So is that a problem or a solution?
It's a problem, but we can make a solution by adding more beds.
Okay, so thinking about capacity again, good. There was another one, George?
Improve turnaround time for imaging or lab tests.
Okay, so the testing, and actually we should break down testing a little bit, right? So there's the wait for testing, right? So some of the work that we've done recently said, gee, you come in, you're sick to death of this, I'm sure. So just cover your ears and like play spelling bee or something. But it's actually a really nice example because it was something that's kind of quick and easy, solves a problem you can understand. So having chest pain, I show up at the ED, there's a protocol. The second I walk in the door and say, correct me when I get this wrong. When I walk in the door and say, I'm having chest pain, Lainey, what's the first thing they do?
They're gonna do EKG and they're gonna do troponin tests.
So they're gonna do an EKG, they're gonna do a blood test, and they're gonna say, nope, you don't seem to be having a heart attack. And then what are we gonna do, Jade?
Stress testing.
What's after the first troponin test?
Second.
We're gonna do a second troponin test 2 hours later. Thank you for coming. We're gonna do a second troponin test 2 hours later. Now those results come back and we said, still not sure. We're gonna have you do a stress test. What is the average weight for a stress test, Lainey?
After you put in the order, it's like 10 hours. No, after you put in the order, it's like 10.
Okay, 10 hours waiting for the stress test. Okay, so if I could have gotten that stress test 10 hours sooner, I'd get out 10 hours sooner. That doesn't mean it's easy to make that happen, but maybe it is. This is why we try and identify things to have the question. So I could get the test faster. I assume I could result the test faster in some cases, maybe, right? So are there cases that you get the test, but then we're waiting a long time, and this might come back to communication, right? The result is there, but nobody told you that they've got the result. Or it's a push versus a pull system, and I don't know the test has come back. Yes.
So I'm not sure if this might be a pedal, but some testing processing can take like longer than others. So maybe the speed of the testing.
I'll do the one that's faster. I'll give me 1 second faster versus slower, or maybe I don't actually need to do that test. Go ahead. I think if, so again, I'm gonna try and kind of, to Jade's point, I want to think a little bit about what is the strategy or the tactic. So strategy to me is sort of how we're going to go about doing something, and the tactic is how you make it happen. So if what we've identified as a problem here is that it's this peeling of the onion layer, right? If what we've identified is, oh, the reason that the patient is here so long is because they don't get the test, and therefore they don't get the test result, and therefore Steve can't diagnose them, and therefore Ben can't decide what treatment plan, and therefore they can't go home. And now as we dig deeper and deeper, we discover what is the reason it's taking them so long to get the test? There's no one in transport to bring them to the place where they get the MRI. We did a project years ago looking at chemotherapy and all the scheduling issues that go around getting patients in to get their chemotherapy infusion. Problem was we didn't have enough people doing blood draws 6 steps earlier in the process, and it all snowballs. Jake.
We can make decision faster.
Okay, so we could improve our diagnostic process. Right, so once I have all of the tests, how do I actually decide what to do with this patient? We are getting very close on time. I want to kind of highlight one thing, and then I just want to warn you, this is sort of where we're going to be for the rest of the semester, except with people who know a lot more than I do standing here. But when you think about getting down to the point where we said, okay, I want to actually decrease the time that it takes to wait for the stress test, or I want to do a better job of selecting what tests that I need. And we start saying, how do we actually do that? And you say, well, maybe the way we can do the test selection is we can use machine learning to predict something, whatever. You need to be thinking not just about kind of medically, how does this work? But one of the things that we discussed last year in a similar conversation was this idea of, well, what if you could change EMTALA laws, and you could say if a patient comes in their severity level 4 or 5, we're going to provide them with an ambulance or a taxi or a voucher to go to an urgent care clinic that could get them through faster. But there's documented bias in the assignment of acuity scores, right? So maybe in doing this, we benefit a lot of the population while actually causing harm to some subset. One of the things we talked about with some of this testing is, instead of having you wait 10 hours to get your stress test, what if we discharge you, but we guarantee you have an appointment first thing in the morning, right? So you're actually potentially going to get the test faster. Turns out that if I get my stress test while I'm in the ED, it is part of the bundle of care. And if I get it while I'm an outpatient, depending on my insurance, I need prior authorization, and prior authorization can take 2 weeks. Or I potentially have a totally different copay, or I'm paying out of pocket for that. I could potentially improve my testing by reserving some capacity. But maybe that's taking the capacity away from the ambulatory space. So now we've got people who have to wait so long to get the test in the outpatient setting that they say, the heck with it, I'm gonna try my luck and see what happens if I show up at the emergency department, which is going to make the problem worse. Or they wait so long to get the test in the ambulatory setting that they deteriorate and they actually need to go to the emergency department. Or I take capacity away from inpatient. And so now a patient who's discharged from the inpatient space is limited only by that one last test for confirmation, doesn't get discharged, which means that someone who's boarding in the ED doesn't free up a room, which means that we now have patients getting treated in the hallway or waiting in chairs again. Okay, so we'll have Andy next week. We've got some great, yes, go ahead. It should be 4:30 to 6, but we can stay longer if you'd like. They may have it. We are 4:30 to 6.
News to me, let's go.
Yep. But we can stay if you'd like. Sorry for the confusion. I think, can someone, George, just check what's on the flyer. Do you remember seeing? Anyway.
I was 6.
The good news is we just gave you a half hour of your lifetime, it's about 12 weeks, so use it wisely. I want you though, the slides will be up on Canvas if they're not already. I want you to be thinking about, as we go through this exercise, when someone says, oh, we can do it this way. There are sort of two jobs. There's I want you to tell them all of the reasons why this idea is gonna fail. And then I want the person next to you to argue all the reasons why, no, it's not. So Steve says you can't do that because of EMTALA. And I say, so we get a bunch of health policy economist kind of people who prove that patients are actually better off if we do this and we get them to change the law of EMTALA. And then Steve says, yeah, but then you're going to have this bias in the data that da. And then we say, we're going to do this. I want you to be pessimistic so that you can be optimistic, right? When you find fault, you're not trying to tear it down. You're trying to ensure that it can work. And frequently what doesn't work triggers an idea that does. Anyway, we will see you all in a week for an hour and 20 minutes, not an hour and 50 minutes. Again, we'll have Andy Fine from Emergency Medicine next week. And the readings for next week should be up, if not already, I would think by sometime tomorrow morning. And thank you to everybody who joined on Zoom, and in particular to our clinical partners for sharing their insight. And hopefully we will be coming back to them with ideas that make their jobs and their lives a little bit better. So thanks, everybody. Thank you.